Marty Goldman. Welcome, everyone, to our February edition of Controversies in Cardiology with our visiting professor, Dr. Amin Murat Tusku from Cleveland Clinic, Dubai campus. The topic today is actually very interesting. It's one that we visited probably around 10 years ago with Peter Libby, and I can guarantee the content of the discussion will be significantly different than it was 10 years ago. Let me just tell you about next month, which is in March 21st. Dr. Clyde Yancey from Northwestern will be here, and the controversy is going to be on hypertension, how low to go. In April, we have Greg Feinero from UCLA. In May, Dr. Jim Thomas from Northwestern, formerly of Cleveland Clinic. And in June, Marty Leon from across town at Columbia. The people who are going to be on the panel for this, what promises to be a very hotly debated topic on identifying vulnerable plaque, does it matter, will be George Dengas, who's Director of Cardiovascular Innovation, Dr. Zahi Fayyad, Professor, Department of Radiology and Medicine and Cardiology, and Director of the Sinai Translational Molecular Imaging Institute, Dr. Kinney, Annapurna Kinney, Professor of Medicine, Director of Cardiac Catheterization Lab here at Mount Sinai, and Director of the Interventional Cardiology Fellowship Program, and Dr. Jagat Narula, Philip and Harriet Goodhart Professor of Medicine, Cardiology, and Associate Dean for Global Health, Mount Sinai School of Medicine, Site Director for Cardiovascular Program at St. Luke's, Roosevelt, and Beth Israel in Bronx, Lebanon, as well as Director of Cardiovascular Imaging, Mount Sinai Heart. And we're very pleased that Dr. Valentin Fuster, who's been the moderator since the inception of this program, will do it this evening. He's Director of the Zena and Michael Wiener Cardiovascular Institute, the Marie-José and Henry Kravis Center for Cardiovascular Health, and Richard Gorlin Heart Research Foundation Professor and Physician-in-Chief at Mount Sinai, as well as Editor-in-Chief of the Journal of American College of Cardiology, and Dr. Narula is Editor of Journal of American College of Cardiology Imaging. Without further ado, the topic was of the vulnerable plaque, does it matter, will be introduced by our fellow, Crystal Engstrom. Crystal?
All right, I want to thank everyone for being here, and Dr. Tusku for a great lecture this afternoon. And so in a few minutes, I'm going to try to summarize what we know about the vulnerable plaque. So atherosclerotic coronary disease remains a major healthcare burden despite modern medical, imaging, and device therapy. It is responsible for over 50% of all cardiovascular events in individuals under 75 years. And while coronary heart disease deaths have declined over the past decade, projections are that by 2030, the prevalence of CHD will be around 18% greater and will remain the leading cause of death in adults. So well-established risk factors for the development of coronary heart disease include hypertension, smoking, adverse lifestyle habits, elevated blood cholesterol levels, and diabetes. And this was well established from the landmark Framingham study that followed individuals since the 1930s, and a scoring system was developed effectively, identified and risk-stratified persons who were at risk for coronary events who would benefit from preventive treatments. Risk factor scoring systems have now evolved to include large and racially and geographically diverse populations, and to incorporate also imaging data, such as the coronary artery calcium score. All these methods have proven useful in predicting coronary disease, but still don't include certain populations at risk in any given individual, such as hypercoagulability and hereditary disorders. Therefore, this may lead to undertreatment of certain populations. Coronary disease has also been extensively studied at the histopathological level. Researchers found that it is a systemic process involving multiple factors, including and not limited to lipids, tissue proliferation, inflammation, and in its early stages, atherosclerosis consists of non-significant fatty streaks, and these can be found in the aorta even in the first decade of life. These then transform into plaques filled with lipid, inflammatory, and smooth muscle cells, and necrotic debris. Then if a fibrous cap forms over the plaque and ruptures, this can cause thrombosis and vascular occlusion. So the notion of plaque rupture stimulated researchers to focus on the concept of this vulnerable plaque, and which was responsible for sudden cardiac death. Davies, along with other pioneering investigators, then discovered the role of inflammation and immune system in plaque instability. Then more recently, the term thin cap fibroatheroma came out, or TCFA. And this occurs when the fibrous cap experiences thinning and was thought to be one step before rupture and thrombosis. So the TCFA became what we know as the vulnerable plaque. And then research with modern imaging modalities, both invasive and non-invasive, have provided real-time visualization of the plaque to even molecular levels and has shed new light on pathophysiology and the burden of disease. Invasive studies, such as intravascular ultrasound, OCT, optical coherence tomography, and other additionals, such as near-infrared spectroscopy, performed in patients with ACS, revealed that the presence of multiple TCFAs and silent plaque ruptured in vessels that were not the culprit vessels. Also surprisingly, a high percentage of individuals experienced recurrent ACS within several years of the initial PCI, and it was attributed to these non-culprit, mildly angiographical lesions. Intravascular imaging has also proven to be useful in evaluating characteristics of the plaques that are associated with events, and also the effects of statins on these plaques. Even short-term treatment with statins, that was published by a study here by Dr. Kinney, result in the reduction of lipid core and improvement in hemodynamics. So although fascinating in their potential, invasive imaging modalities are inherently limited to symptomatic patients and may not routinely be applied as screening tests. Contrast-enhanced CT has gained considerable popularity over the past decade. Plaque characteristics on coronary CT, such as high positive remodeling index, napkin ring morphology, and low attenuation, were shown to be independent predictors of ACS. When assessed hemodynamically by FFR-CT, plaques with these features were also found to be associated with ischemia, irrespective of the degree of stenosis. Another imaging modality that has proven useful is the B-mode ultrasound with pulse wave and color Doppler. It is a safe, low-cost, and globally accessible imaging modality. Multiple studies evaluating the carotid arteries have revealed a strong association between the presence of plaque and the development of stroke and cardiovascular disease. Furthermore, ultrasound has recently been shown to be useful in screening asymptomatic individuals. An ongoing study, the PESA study by Dr. Fuster, is a study that is prospectively following asymptomatic middle-aged individuals for the development of cardiovascular events. Initial data reveals that even in this low-risk cohort, atherosclerosis is present in the iliofemoral region and is associated with plaque in the aorta and also with elevated coronary calcium scores. So this emphasizes one important concept, that atherosclerosis is a diffuse disease and demonstrates that screening with a low-cost imaging modality that's non-invasive can assist clinicians in stratifying asymptomatic individuals and maybe intensify treatments or prevention treatments. As a final point, it's worth mentioning that certain clinical characteristics of atherosclerotic heart disease appear to be evolving. The incidence of ST elevation MI is decreasing while the rate of non-ST elevation MI is increasing. Also, the risk factor profiles for the ACS patients are changing. More younger patients with insulin resistance and more women are experiencing MIs. As data on plaques associated with stroke and NSTEMI reveal that they possess more stable characteristics, authors have suggested that the use of statins may in fact be changing the characteristics of the vulnerable plaque. These findings underscore the need for a change in the approach in atherosclerosis from a well-described vulnerable plaque to maybe a more global assessment of the vulnerable patient. So in conclusion, we learned that atherosclerosis, rather than being a focal process, it's a diffuse disease, and that one, plaques are abundant and present throughout the entire vasculature, even in low-risk patients. Number two, not all plaques with these so-called high-risk features will rupture. And number three, many high-risk plaques rupture but are clinically silent. So future efforts should perhaps shift focus from identifying and treating the vulnerable lesion to employing the traditional risk models coupled with some other non-invasive imaging modalities to better predict future coronary events, risk stratify individuals accurately, and implement preventive treatments in a cost-effective manner. Thank you.
Great job, Crystal. Really, very well done, and an excellent manuscript on a very difficult subject. So, good. Let me welcome Dr. Murat Tuscu, who is visiting us today from the Cleveland Clinic and from Abu Dhabi. And I'd like to say a few words about him. He's certainly a very, very well-recognized individual in the field of cardiovascular disease. I would say that he was born in Istanbul, or at least was born in Turkey. He attended medical school in Istanbul, where he had his internship in medicine and so his residency. Then in 1985, he came to United States, and he had his fellowship in cardiology and in interventional cardiology at the Cleveland Clinic. Now, in 1989, he spent a year at the Massachusetts General Hospital as a special clinical fellow in research. So then from 1990 to 1992, he became a staff member of the University of Pittsburgh, and then he became assistant professor of medicine, and then he moved again to the Cleveland Clinic, where he was first associate professor of medicine and then professor of medicine. He became director of the intravascular ultrasound lab and eventually vice chairman of the Department of Cardiovascular Medicine. And now since November, he's spending some time as a delegate from the Cleveland Clinic in Abu Dhabi, where he's chairing a huge enterprise, including cardiovascular medicine. So he has many accomplishments. He's in the editorial board of the top journals, so Jack. He's in the editorial board of the three Jacks, so you're really something. I don't think this is legal, actually. But I would look at. No, but he actually is in the editorial board on a number of journals, and certainly he has been a pioneer of many aspects that evolved from the American College of Cardiology, the intravascular ultrasound expert consensus writing group. Then he was in the program committee from 2006 to 2009 of the annual scientific sessions, and actually he chaired the scientific sessions in 2012, and he's in the board of trustees of the American College of Cardiology at the present time, between 2011 and 2016. He has a significant number of awards, which began when he was a fellow already, and then at the Cleveland Clinic, a Training Fellowship Award, Outstanding Teacher Award of the University of Pittsburgh, and then a Simon Dack Award on the editorial board of JAC, Teacher of the Year Award, Interventional Cardiology at the Cleveland Clinic, and so forth. So what is interesting about him is that he has been involved in so many studies. Actually, he has been involved, co-PI or PI, and some from NIH studies in 80 of them. So he's really has accomplished a lot, and we know by looking at his CV is near 300 papers in a very in the top journals. And actually, the first paper is interesting. It's psychological problems in the coronary care unit. So he moved from the head to the heart, and he has done very well. Well, congratulations, and thanks for visiting us today. And I'm going to give you a plaque to remember your visit. And I know the fellows enjoy a lot the discussion that you have with them. So here you have the faculty and fellows, etc., etc. To Murat Tuscu for outstanding teaching, wisdom, and expertise. And you know, this is the visiting professor Anandi Sharma, is Dr. Sharma's father. And then the Simon Dack, that I'm sure you remember him, memorial lecture. Congratulations.
Thank
okay?
you very much. Thank you. Thank you very much. Thank you very much.
I give you this. This put in your pocket. Thank you. Now you can sit here in the middle, and we are going to call all the experts in the field, which is Dr. George Dankas is here. All right. Saki, Fayyad, Anukini, is she here? Yeah, okay. Jagat Narula, and obviously Crystal, who actually wrote a wonderful paper. Well, this is an interesting subject, which one may begin by saying maybe more talk than substance. But before we go any further, I don't want to be apocalyptic, but I will read you the title of the last two articles written about the subject of the vulnerable plaque. First article, The Myth of the Vulnerable Plaque. And the second, The Requiem of the Vulnerable Plaque. So with this in mind, let's discuss the vulnerable plaque in the future. Is not a good presentation, Dr. Jagat Narula? All right. You like. This is a very interesting subject, by the way. Very interesting. That I like to approach it historically, and I would like to provide an index of how the discussion is going to move. We go first between the 1950s and the year 2000, where the anatomy of the coronary system evolved, and in parallel, Framingham evolved. So there were two aspects. One is understanding of the number one killer, and the other is how to prevent it. And this really was about 50 years, which were quite fascinating. Between 2000 and 2010, evolved the issue of diagnostic imaging. Diagnostic imaging of the atherosclerotic disease focused in the coronary arteries, systemically, intravascular, and so forth. And then between 2010 and 2015, it became like an obsession driven by the interventionalists about the vulnerable plaque. This concept comes from many, many years, but it became very obsessive at this recent time by the question whether you could identify the plaque that would kill people. And then we have from 2015 to 2025, the evolution is making a significant turn into imaging, assessing the burden of disease, and then to move on in a completely different direction that just try to identify the plaque that is going to rupture, which is quite difficult. So I think what we're going to do is let's start 1950s to the year 2000. And as I mentioned, two things evolve in parallel. One is the understanding of the atherosclerotic process in general, and the other is the Framingham, evolution of Framingham. Just like actually Erling Falk and I wrote the chapter about the subject of today in the book for Hearst, and I just want to make 2 or 3 statements, and I will ask Murat if he is in agreement with. First statement, atherosclerotic disease is chronic, lipid-driven inflammatory disease of the arterial wall leading to multifocal plaque development. The speed of the disease progression varies greatly, but it usually takes decades to develop to the advanced atherosclerotic lesions responsible for the clinical disease. What is very interesting, we'll talk, is the plaques are very heterogeneous in size and composition, even plaques that are close to each other and exposed to the same systemic risk factors. And most plaques remain asymptomatic or subclinical disease. I guess it's just to put something in the context, which we know is the number one killer, and I suspect you agree with all these statements, Murat.
Yes, I think that you raised several very important points. While our understanding started to evolve about the anatomical aspect of coronary disease, in the clinical arena, in the cath lab, we were reacting to our understanding by intervening to every single lesion, because our understanding in 1980s and early 1990s was very lesion-driven. So we thought that if we treat the lesion, we would be treating the patient and the atherosclerosis, which was of course wrong, but so it was very attractive to us to find the Holy Grail, to find the vulnerable plaque, because we would then be not only treating, but also preventing. At that time, I started in 1990s, 1992, I think, doing systematic intravascular ultrasound studies, not only in patients that have coronary disease, but also in transplant recipients. And there, I got the first sense that this disease is much different than what angiography at that time allowed us to understand. And it is, first of all, much more diffuse. And then it's exactly as you said, it was very variable. And then also the remodeling phenomenon, we wrote about that in 1990s. Remodeling phenomenon was also...
We'll talk about this in some detail now. Now, let me move into the other side, which is as the risk factor profile evolved from Framingham. And it's interesting, Framingham and eventually other organizations, they came up with 7 risk factors affecting coronary artery disease. And it's quite interesting because today we are told, and we read constantly, the patients don't have risk factors. The patients don't have risk factors. Let me give you the data. The 7 risk factors we are really talking about, I like to divide it, the 2 mechanical ones, which is hypertension and obesity. And then we have the 2 chemical ones, which actually is high cholesterol and then diabetes. And then the question about you smoke or you don't, you practice exercise or you don't. And then the issue of diet, but not in the terms of obesity. It's just poor eating habits that may raise cholesterol. The whole issue of Framingham evolved. It started with 5 of these risk factors, then it moved into 7. This is irrelevant now. But it has been a drastic change in the last 3 years in 2 directions. And I would like to point this out. First, we are now looking at the healthy individual. And that is the same risk factors, you don't have them. You go one by one and you say you're 0. When you look at that, only 3% of the population in this country and 2% of the population in the United States are free of all these risk factors. So the concept that we have people with disease and they don't have any risk factors is absolutely wrong as you look things from the other side. And Jagad, what is your opinion on this? You know, this is happening, it's a new approach that is taken today.
Fully agree with that the approach that, and specifically the same approach that you have been talking about in terms of not going towards the disease, but talking more of wellness that you have been doing specifically since the Institute of Medicine recommendations that you had made and which were accepted by the United Nations high-level meeting. So I think it's absolutely right that the not having the risk factors is a myth.
So, so we have to be aware that the concept that there are no risk factors is really going away. It's just looking at things quite differently. Well, having said that, we are going now to perhaps penetrate a little bit more into the anatomy that, as we say, I made few statements to start with. And first of all, we all know this is a systemic disease, and we will talk more about it in a moment. And in fact, the driving force today is that you look at any region, and if you see atherosclerotic disease, you can almost predict that coronary artery disease is going to develop. The opposite is perhaps different. You might have coronary artery disease and not much disease in the other regions, but in general, what is evolving is this is a very general disease, and in a way, you can use the different regions to assess whether or not coronary artery disease may be present. Well, I'd like now to get into how it evolved, the vulnerable plaque, and go into the detail of the 6 components of the vulnerable plaque, because this is critical to understand imaging later on. And I'd like to start by saying what everybody's in agreement due to the work of Davis and Falk, and that is 75% of the acute coronary syndromes is, in fact, is a rupture of a plaque. And in the other 25% is an erosion, probably is a hypercoagulable state, touching an artery that is de-endothelialized, but the hypercoagulable state is enough to cause an acute coronary syndrome. So we have plaque rupture and plaque erosion. I think one of the most interesting developments in the last few years has been the progression of the disease, that today everybody's in agreement. Most of the time are tiny clots, mural clots that get organized in another small rupture and gets organized and so forth, and the disease progresses. So now I'd like to touch into the different aspects of plaque rupture and to go one by one. Okay, we said at the beginning that this is a lipid-rich plaque, the way things begin. Well, maybe hypercholesterolemia or not. But talking about the vulnerable plaque, Fahi, you know, you have worked a lot in this business, and you know, looking with PET and looking with MRI, the question is, can you see that fat or the inflammation?
So inflammation, yes. Today, I mean, the best tool we have non-invasively would be positron emission tomography using fluorodeoxyglucose as an analog, and an indirect way, if you will, to look at the inflammation. There are new tracers that are more cell-specific. They're really on the horizon and look extremely promising. So I think when we think about detection of inflammation with PET, I think we're on the good road right now. The other component would be better assessed non-invasively with magnetic resonance imaging. So looking at the cholesterol esters, the lipid component, the necrotic core, magnetic resonance imaging is fairly strong. It is not as strong as we want it to be in the coronary artery, but it is very strong in the outside the coronary artery. Exactly. And then finally, CT, although CT is not a molecular imaging technique, but CT is very strong in the coronary artery. Yeah. And then you are able to differentiate the non-calcified plaque versus the calcified plaque. And maybe with better detectors, I think in the future, we may be able to get a little bit more on the tissue composition. And I'm really commenting here non-invasive.
Yeah, we'll talk in a moment. I think the only question I'm going to ask you in a while is that it has been a misunderstanding of PET. Just thinking PET identifies inflammation in the vulnerable plaque, when in fact there is more inflammation in the disease that is not vulnerable. Exactly. But we will talk about this in a moment. I don't want to distract. Yep. Now, I'd like to ask George, the second component is the cap that really surrounds this particular lipid process. Now, what do you think the technology, certainly technology like CT, MRI, and so forth, I don't think they are too good, even in the carotid arteries. But what about the intravascular techniques that you use? Ultrasound, OCT?
It's interesting because a few years ago, we thought that ultrasound was already very high definition, and yet there's still more to be captured by OCT. And even OCT itself had to have a few generations in both in the technology and the image acquisition protocol to allow the fibrous cap to be imaged, I think, accurately. That's the power of OCT. The fibrous cap is right next to the lumen. The penetration is not very good, so it cannot show structures deeper inside, but it has a great distinction. The fibrous cap, we're talking about 80, 100 microns, something like that. I mean, how can you image that non-invasively? I think that's a very formidable task, at least right now. So OCT has itself gotten a few generations, and finally, I think we can say this can be measured. And I know Dr. Kinney primarily has done a lot of work about this particular aspect in clinical trials.
Crystal, before we go any further on all the other components, you mentioned your paper again and again that one thing is to look at the plaque when you do a catheterization. The other thing is to look at people who walk in the street, which you cannot use such technologies. And I just want to point out that only 1 of 1,000 people in this world undergo cardiac catheterization. The other 999 do not. So I think we have to put things into prospect when we talk about technology. Who are we aiming at? And I'd like you to comment because you make very good statements in your.
So yeah, that makes a good point. My comment is that with the imaging, invasive imaging technology and other, MRI and PET, we have been able to understand the plaque, the characteristics, and we know that certain characteristics are associated with events. However, the people who, undergo catheterization are not patients that are, going on screening tests who are asymptomatic and low risk. Those are patients who are having symptoms, who have acute coronary syndrome, and those are patients who do benefit from invasive treatments of certain lesions because they're having, active ischemia or they're having an event. So I think these invasive imaging studies have been very useful because it's shed new light on what the plaque is. But in terms of, what's going on in the general population, that's a different story. So maybe in that, non-invasive imaging is a little bit more useful because it doesn't put the patient at risk.
I'd like to comment about, actually, when we wrote this paper, Erling Falk wrote to me and say, we have to clarify one term, and he's quite correct. Coronary artery disease is quite different than ischemic heart disease. I just want to point this out, because when we talk identification of disease, the disease is not necessarily ischemic. We are just identifying plaques. And I think we have to really use the appropriate terminology. If we talk about clinical disease, we should talk about ischemic heart disease. If not, we should avoid the term. But having said that, Anu, I want to ask you a question which has to do with remodeling, which is the third issue. And this is fascinating. This is where has been a huge misunderstanding. Remodeling, there are two types. One is you have a big plaque and you open up the artery and it's all extrinsic. And this is why angiographically you might not predict an area that appears to be normal and actually is not. In constrictive, the plaques tend to be smaller. I'm just saying this because when you go into the literature about the prospect trial in many trials, there's so much confusion. They say the plaques have to be large. Sure, they are large, but you don't see them because it's remodeling. So I'd like you to comment about this. It's also an issue of terminology.
That's a very interesting point which Dr. Fuster brought, that we always talk about positive remodeling and negative remodeling, and which part of the atherosclerosis we are talking about. And I think which, everybody talks about right now is the prospect trial, where we know the plaque is large. And just going back to the point of invasive imaging, just go back is what most of us are used to, or which used to be in the past, used to be intravascular ultrasound, which uses ultrasound. And penetration with the ultrasound is better, goes anywhere between 5, 6 to 7 millimeters down. So you are able to see the plaque that Dr. Fuster is talking about, the large plaque. And this, I think this is a large plaque that you start with a large plaque, and with the, what you also see is along with the large plaque is the lipid in this plaque. So that is why I think when it comes to what is called as, what prospect trial mentioned, is that you need to have a large plaque. They need to be lipid inside that. And on top of that, you need to have a thin cap so that sometime, for whatever reason, the patient's milieu changes, that's the time that thin cap may rupture, giving rise to ACS. But the question always is, what is the incidence of finding this kind of a plaque? And even if you find this plaque, what's the incidence that they will truly give an event to the patient? So that is one part of, the large plaque that he was talking about, that everybody is scared. As soon as you see a large plaque, the likelihood that will have lipid is also very high, which also actually, published that from our trial, which was the yellow.
So what you're saying is a large plaque not necessarily is obstructive, but maybe very vulnerable.
Vulnerable because they do contain a lot of
Absolutely. Now, maybe I will ask George again. The issue is plaque hemorrhage, which, at autopsy has been found again and again, and this is the vasa vasorum, I guess. Do you see this with this type of intravascular imaging technologies?
Not with the standard ones, but there is some research in this area, because a hemorrhage will lead to an abrupt increase in the volume, and depends on what the compliance of the plaque is and the compliance of the cap. It may promote some unstable event from the inside of the plaque. And that may make some sense. And we know that some of these events have been associated with thrombolytic drugs or other aspects that can also produce this type of effect in the plaque. And there's several reports sometimes of MI, they go in the pathology and they find hemorrhage inside the plaque.
Jagat, it seems to me diabetic patients with this friable vasa vasorum are very prone to that hemorrhage. Is not correct?
Yes, and the only problem is that we can't identify them. The most important way of identifying them in the non-coronary beds, and I think Zahi can point it out much better, that with the T2 star imaging and all, with the MRI, we can identify the presence of hemorrhage much better.
Before we get into calcification, maybe there are several aspects that are important about diabetes, and that is that the diabetic disease is so bad because vasa vasorum rupture, the red cells are there, and the hemorrhage, and then you get an inflammation that tries to phagocytate the red cells. In such of these, in 50% of the diabetics, the inflammation doesn't work. They have a genetic negative attachment of the receptor. And I'm just trying to explain that the diabetic patient, this vasa vasorum, which is like microangiopathy, is what probably leads to so diffuse and bad coronary artery disease and systemic disease. But leaving this, I want to really get into calcification, Murat. And I just like to maybe making one or two statements, and then I'd like you to get in. Calcification has nothing to do with the degree of obstruction of coronary disease. I'm talking about coronary calcification. It has to do with the burden of disease. This has been shown again and again when different technologies are being used. The second issue is calcification is a healing phenomenon. It's not an active pro-coronary phenomena, and that is as lipids get reabsorbed, calcium comes in, and so forth. So I'd like just to ask you a feeling about calcification, because those of us who are skeptical in doing calcium score twice, for example, you give statins, you heal, and there's more calcification if you don't give them. Give us a sense of that particular process, because this is one of the most interesting tests today in terms of risk stratification. I'd like you to comment on.
I think that calcification that we see on the coronary angiograms or intravascular ultrasound are fairly large calcification, and it's a sign of the age of the disease. It's a sign of healing, as you said, just like in any other chronic inflammatory disease such as tuberculosis and so forth. But there's also this microcalcification that we start to talk about. Perhaps it is in the evolution phase of the plaques, in younger plaques, and the spotty microcalcifications that may really mean different than the calcification that we see in our clinical practice. I agree with you that the calcification is not a good thing to follow on the CT scans for improvement, and it has been shown. And I think it's also important to know that calcification that is detected on the coronary tree does not necessarily indicate a vulnerability or problem or an obstruction at the site of the calcification, but rather it signifies the most important anatomical risk factor, that's the total atherosclerotic burden. We have seen this, this is well documented, I think, in the angiography literature. It's very well documented in the IVUS literature as well.
I think this is a critical issue for two reasons. One is we see calcification of more than 1,000 Agatston score. And in fact, you don't see obstructive disease, you do stress tests and are negative. And we see this all the time. So I think the question about calcification is a marker of disease, but not necessarily is a marker of significant obstructive disease, and I think that's quite important. And the other issue is the data that is evolving with the statins. You give statins and the calcium score goes up because we are taking the lipid material out and is substituted by calcium healing. So I think these are issues that are quite interesting to take into account. Now, the other aspect, we didn't touch too much, Zahi, about the inflammation. I asked you more about the lipid, but maybe it's time that the CAP has some inflammatory macrophages, and then the necrotic core is basically macrophages that are dead because they release all the enzymes and they die and so forth. So I just like you to give me a sense of the PET scanning, because it seems that the inflammation is more prevalent everywhere, regardless if the plaque is vulnerable or not, which the inflammation is not too significant in terms of intensity. Give us your feeling.
So I guess to bring it back maybe from the calcification aspect, that because of some of the PET methodology that's available today, there are more specific tracers to different types of calcification. So work by Mark Dweck, who's here doing a mini sabbatical with us from Edinburgh with David Newby, the work that they showed in the Lancet about the use of sodium fluoride and the detection of microcalcification, which comes right after inflammation and before the macrocalcification that we see on CT. So there may still be a role to better understand calcification, and maybe with different methodology try to tease out these risks that can be picked up by these tracers. So that brings me again to the aspect of PET. And today, the best thing we have, and the most validated one, is fluorodeoxyglucose. And it's not perfect tracer, as you said. It is picking up inflammation, but we don't know if this is the inflammation that's going to lead to an event. So we don't have that prediction. But it is specific to the type of macrophages that are supposed to be the ones that are the bad players compared to the ones that are more involved into the subtype of macrophage. Still, we would still like to have a better tracer that's more cell-specific. So this way, I think we will be much more accurate. And the hypothesis to test, maybe we have the chance to test this, this year or next year, is to see if these better tracers that's more specific to the macrophage cell type are the ones that are going to be helpful to differentiate between a high-risk patient or a high-risk plaque versus a low.
So what you're saying is the inflammation is different in the vulnerable plaque than in the other, and I accept that. Jagat, I'd like you to, I am a doctor, and I have a patient in front of me, and we discussed thus far what has been going on, but I want to do CT angiography for whatever reason. One is that maybe we can avoid lots of stress testings and are much more specific. You have been an advocate that this particular technique can be giving you a sense of vulnerability. Can you tell us what do you think about these negative shadows that you see, and whether this is fat, and tell us a little bit about CT angiography.
Dr. Fuster, all the non-invasive techniques that we have available to us, and specifically when we talk about the coronary arteries, the only technique that can, at least at this point in time, can tell us about the plaque characteristics is the CT angiography. And the two most important features that we are able to see, which are very gross features, and that is, one is the presence of the low attenuation plaque. When you compare it with the intravascular ultrasound, if the Hounsfield unit density of the plaque is less than 30 units, maybe going into the minus levels, that is something that represents the presence of the necrotic core. And the second important thing is, because of these necrotic cores, there is a positive remodeling. So these two features, we consider that they are the best, they best characterize the plaque, which is vulnerable to the events. And in our study, which was in 2009, that was published in JACC, we clearly demonstrated that the 45:1 hazard ratio that you get when these two features are present versus these two features are not present. However, when we look at a much longer follow-up, when it is 3,000 patients with a 10-year follow-up, where you were kindly one of the authors on that paper, and we discussed that the total number of the cases which are vulnerable and then they evolve to become stable versus those which are stable and they evolve to become vulnerable, that almost is equal. So basically, it takes away the importance of the vulnerability, and it again focuses on the disease.
I understand, and I read these papers, but I want to go to Crystal.
Right. But there is one important thing which I
It
want.
has to be very important for you to
Very
continue.
important, Dr. Fuster.
All right.
And that is that we always say that it has to be a large plaque, but what we are not started to say, and that brings us to your concept, which you presented with John Ambrose quite a lot of years ago, that at least 30% of the plaques are those which are smaller than 50% luminally occlusive plaques, which result in a rupture. Now, our last
Maybe
study,
large volume.
which is all large volume,
Yeah.
but most of the times they are subclinical ruptures, but those which are actually resulting in an acute event, 30% of the events occur by these small plaques. And our last paper in the European Heart Journal, which is still online and is yet to be published this month, end of this month, which clearly tells us now that even if it is a 30% plaque, it has an FFR of less than 0.8. And the reason is that the plaque has become so large that it has reached its Glegovian limit, that it cannot extend any further. And when you give the nitroglycerin for the FFR, the top portion of the vessel enlarges, the bottom portion of the vessel enlarges, and it creates a bottleneck so that it becomes less than 0.8, giving validity to the fame.
Yeah.
And fame.
No, I think, let me tell you what my problem is. I agree with the information that we have all been involved with imaging technologies over the years. I really don't believe on sensitivity and specificity. I will never do a CT, and I'm going to ask Crystal, I will never do a CT to find out if there are vulnerable plaques there, because what you say is correct, but we lack sensitivity and specificity. We don't know the denominators here. And I'd like Crystal to comment on, because you also mentioned this in your paper.
So although we know we're finding these characteristics, there are still factors that are unaccounted for. Why do some people get it? Why do some people have these vulnerable plaques, and why do other people have the plaques and they don't cause rupture and thrombosis? So that brings the topic of what is going on in the patient's blood, or any inflammatory markers that are circulating. That may lead to one person being more predisposed to clotting and plaque rupture. So
Okay.
I think that's the point, that there may be some factors we're not accounting for.
Okay, Murad, this leads to the third topic we are going to discuss today, which is, can we assess vulnerability? This is 2010 to 2015. That's where all the guys like you really got into the field, the interventionalists. And they said, now we are going to tell you what plaque is going to cause a heart attack. Well, let me go step by step. Let's start with what technologies do we have that tells you that a single plaque is actually vulnerable. We talk about CT angiography, and I agree with what Jagat was talking about. We are learning, and it's interesting, but MRI, you just look at the carotid arteries indirectly. Maybe it tells you the patient is vulnerable, but it doesn't tell you directly the coronaries. The calcification of the coronary arteries, without question, is adding a lot to Framingham. We'll talk about this in a moment. Then you guys says, I'm going to give you the answer. And then you start putting catheters with all the technologies, and I think I'm learning something with that. First, the high sensitivity of you looking what is there. There's no question about it. Second, you give us statins with your yellow stuff there, and you can find out how a single plaque can be actually reversed. All of this is fine, but first of all, only one patient out of 1,000 has a catheterization. And even that has a catheterization. I want you to convince me that there is a single study published in the literature that says, I'm going to tell you what plaque is going to cause a heart attack. Just tell me.
There is really none. Because when we first started to do intravascular ultrasound, we were absolutely amazed to see that in patients with acute coronary syndrome, when you do we did a study with just the LAD lesions, and just proximal to the lesion all the way to the left main, we discovered that in 19% of the patients there is at least one more ruptured plaque, let alone vulnerable plaque. We saw a lot of patients with characteristics of a vulnerable plaque. So I don't think that anybody can go in and then say not this, but that vulnerable plaque is going to rupture. That's very clear. That I think is the soft belly. That I think has changed our minds. There's a French study all the way from 1990s that showed that it's almost 60% of patients have, when you do 3-vessel intravascular ultrasound, that has multiple so-called vulnerable plaques, multiple ruptured plaques that you don't even know about. You see, that's the problem, that some plaques rupture, don't thrombose. Some plaques rupture, thrombose, and heal. Some plaques look very ugly. They don't cause any problem. And also, I think that the widespread use of statins also changed the landscape completely. So this whole concept of vulnerable plaque and sealing, we used to think about in 1990s, sealing the plaques, I think that is far out there. It's for the time being, it's just also you got to take into account the blood and the other factors that got to be right.
Okay, thank you. Anu, tell me about the yellow stuff.
Yeah, before we go to the yellow, I just want to, just go to your question about one trial, maybe the prospect trial actually, which has been published and a lot of people, talk about it, is that when patients had ACS and the culprit vessel was done, non-culprit had VH, is a different kind of ultrasound study, and what they showed was the same in a non-obstructive, non-culprit lesion. If they were characteristic, which was, the lot of plaque burden was, we say the same plaque burden, and then there was stenosis of the vessel on the patient as well as thin cap. If there was presence of all these three, there was a 17% chance of them having subsequent MI at follow-up. So there was, one study to say, but the question is the same. You will have multiple of this lesion in multiple vessels, and you cannot predict which of that lesion will cause it. But there are several other ongoing studies. I think in the next few years, we will have maybe the answer for, this kind of the study that we are talking about.
What you say is correct. They put together the concepts we have been discussing: large volume, non-obstructive, fibroatheroma.
These are obstructive.
These were obstructive because they wanted the lumen to be less than one particular, that was less than 4 millimeter lumen.
But I say the patients who had the events, were non-obstructive. That's the issue.
Yeah.
And that's why it's so hard to predict when you do angiograms, but you have to do the special imaging.
And there are 3 studies. One is the prospect, one is the viva, and one is the athremo. So there are 3 studies which have all shown the similar findings, that if you get these features, and all have shown the same features, that if these features are there, the plaques are likely to have an event over the next 2 to 3 years period of time.
Murat?
But just a brief comment, but the events are revascularization for angina and unstable angina, not myocardial infarction by and large. I think that the event rate is so low. And then in the prospect too, most of the events are revascularization for angina, so that we're not saving lives. We are not preventing myocardial infarction. That's the issue.
I want to make a point of the 3 studies that Jagat and you will get now into your study. First of all, there were many plaques like those, and those who developed events, which was only an unstable angina, they found that the plaques were the ones we are describing. But when you see many, you don't have any idea which one, and you can put 7 stents, and you don't pacify. So it's very important to see what is the endpoint.
And I'm more than worried about this phenomenon. There are 3 studies going on: Prospect 2, Secret 2, and a Korean study. Prospect 2 looking at the large plaques and sticking these stents in there, which is being done in Europe. Secret 2, which is seeing even the 30% plaque or 20% plaque, and if they have got the thin fibrous cap, they are sticking a stent there. And the worst is the Korean study, which is going to go for 1,000 patients. Wherever they see a lesion less than 50%, they stick a stent. And unfortunately, if that study becomes positive, that will be the biggest disservice to humanity.
Yeah, but the one in the one in Rotterdam, they got more events with the stent in the 30%.
I hope so.
Well, it's not your hope. It happened already. The Rotterdam study. These are the first people who did it, to put the stents in 30% lesions, and they found increase in the number of events rather than touching them. Anyway, look, now is your time for the yellow thing.
Yeah, yellow was not in an obstructive lesion. The study done here in Sinai with a team of doctors, many of them are here with us in the room. So these were obstructive patients who had obstructive lesion. And what we did was once patient with 2 or 3 coronary artery disease, we took care of the culprit. So in the non-culprit, the hypothesis was the same, that what was the plaque composition that we think we can identify, and if they're in the obstructive lesion, and by giving statin, can we change the plaque composition? And by changing the plaque composition, would we change the need for intervention? So all these studies are putting stent, and our study was that can we avoid stenting of this particular lesion? Essentially understanding you have this kind of a plaque. So the first thing that will change in the plaque composition is the lipid will decrease. That means your, the so-called plaque will regress and your FFR will change. So what we actually found was that patients had regular statin or aggressive statin, which means they got Crestor 40 milligram. And we saw that patient who had a Crestor and a reduction in LDL, and what we saw was baseline, and when they came back, which was about between 6 to 8 weeks, that definitely patients who got Crestor change in LDL by at least 20 point, decrease in the plaque composition by change in the lipid composition, and trend towards change in FFR. Means about 8 patients in the whole study did not need a stent when they came back. Instead, they came, they had imaging, their FFR was more than 0.8 and did not need a stent. Proving the point that if we had a larger group of patients, that likely we could have had that positive, saying that if the patient's plaque composition change by changing their lipid content in that vessel, that there could have been that we could have made an argument that there's a subgroup of patients will not need a stent if they really have a good change in the plaque composition. One we did not mention, that we mentioned IVUS, we mentioned OCT, which uses light, and one other technique that we did not mention, though Crystal did talk about it, was NIRS, which also uses infrared light, and all you see in the vessel is red color or yellow color. If there is a yellow color, that means that particular plaque has a lot of lipid, and it gives you a number, and the number ranges anywhere from 0 to 1,000.
Okay, thank you. So let me tell you, we address the subject of what happened between 1950 and 2000 about the anatomical aspects of coronary artery disease, the vulnerable plaque, the prevention aspects. 2000, 2010, diagnostic imaging. We touch about the invasive and the non-invasive, I guess. 2010, 2015, vulnerability. We are a little bit on the sky, all right? Now let's talk about what is happening. And I'd like to present 2 different aspects. One, let's assume I am an angiographer, and I just want to know what's going on with my patient, or I am a CT angiographer, whatever. We have defined a new criteria which is going to be published, and I only present this because it's based on data of the redefinition of coronary artery disease in 5 different stages. I go very quickly. But the stages have to do with how the artery looks like at angiography, and has to do also with the CT score, which is becoming a big hit, I believe, and with some other aspects. Stage 0, you do an angiogram, it's completely flat, you don't see anything, and the patients, this is a calcium score of 0, and these patients, the mortality or the incidence rate of events is less than 0.1% per year. This is all come from the literature. Then comes the stage 1, in which you see mild atherosclerotic disease irregularities, but less than 30%, no more than 2 coronary arteries being affected, and a calcium score between 1 and 99. In these cases, the mortality or myocardial infarction event is 1% per year. The stage 2, these are patients who have, the disease is less than 50% stenosis, okay? and is confined again to 2 coronary arteries, maybe 3, and the calcium score is 100 to 999. And here comes the point, when reviewing the literature, it's so common to have very high scores, but no obstructive disease. And I think this is why we talk about this stage 2. The stage, and this, I already mentioned, the incidence rate of events is actually very small. It's actually 1 to 2% per year. Then the final one is a stage 3 and a stage 4. Stage 3 is that the stenosis is more than 50% with a very high calcium score of more than 1,000, and 1 or 2 arteries are involved. And the incidence rate of events is 2% per year. And the stage 4, with the event rate is more than 4% per year, is more than 70% stenosis, affecting the 3 arteries, and with a calcium score that is high. The reason to do this is to give a prognostic implication, because the key question is, are you going to start giving drugs on anybody who has stage 2 or stage 1? And the reason is probably not, because the incidence rate of events is so low. So this comment that you see some disease you should treat with aspirin and statins, it seems we can disagree on that. And what we're trying to do is to begin to outline the management of patients depending on the degree of what you see of subclinical disease. And that's one aspect. I'd like you guys to comment about this for a moment before we go into the non-invasive technology. Murat?
One can also talk about how long you're going to let the coronary artery be baited with high LDL cholesterol and all those. If in a young or middle-aged person you see early atherosclerosis, I think that there comes this risk-benefit ratio. That's number one. The number two is the progression of atherosclerosis linear, or are there times that it jumps up, which probably is the case. I think that you have, I think in the past talked about this, that this progression of atherosclerosis may not be very linear. And the third piece of information is all this data also show in a way the importance of atherosclerotic burden in the coronary artery. That's I think critical. This issue of 20% lesions causing plaque rupture is really a little overblown in my mind. We looked at this and published in 2013 a large group of patients that had a prior angiogram before their myocardial infarction. And it's clear that if you look at 3-6 months before, there's really the atherosclerotic plaque is not very big. But when you look at if you had the opportunity to look at it by angiogram within the 3 months of the myocardial infarction, actually most of the lumen diameter is 50% stenosis. So the point that I'm trying to make is who to treat is a very tough thing.
Yeah.
I think if there is some evidence of atherosclerosis, and if you assess the global risk, I will be more inclined to treat in patients that I find moderate risk.
I want to emphasize one thing. This data, which is all, you will see it in the literature, is a 10-year follow-up. And we are talking per year. And so what we are trying to say is the whole question today is, do you treat subclinical disease? That's really the key question, not where the vulnerable plaque is. So, and once you are there, it's better you begin to classify subclinical disease. And this is for those angiographers or CT people who see the disease, this is all, and then say, maybe we should be very careful. George Dangas, what is your opinion?
I think it's easier said than done to kind of identify the people who to treat. There will be a very endless gray zone here. I'm not sure that the CT scanning of the calcium score has delivered as much as we wanted at the individual patient level. So I think we'll be looking for a little bit more of refined new imaging to help us there. And I think for some reason, the guidelines always have underestimated the role of the family history as a single factor in this. And I think maybe a little bit more on that should have been proposed. The latest version is bringing up the so-called not so traditional risk factors, which is very important. But again, in my mind, to pull together calcium score with a positive family history at a young age, in my mind, the latter one is much, much more important.
I want
And
to
that
be
might
sure,
be the
yeah,
first target.
I want to be sure you understand. We are going to talk about this right now. I'm talking about the patients who go into the angiogram. What do you do? We have this question constantly. I have seen 30% lesions. Should I give aspirin? Should I give a statin? This is what we are talking about. Now comes the second issue, which is the issue that I think we should be much more aware is the overall population. What do we have in front of us? And I think it's a combination of the risk factors that you mentioned, plus, and I'd like Jagat to comment on, we have data on 10,000 people now with calcium scores and with ultrasound, and I'd like you to comment rather than myself.
Dr. Fuster, that's a very impressive data specifically that has come from Europe, from your group specifically, both the calcification as well as the carotids and the iliofemoral areas. And I think for me, that data is most impressive because it tells me that almost everybody at the age of 45 has started to develop something. And looking at that, although I am the one who has to be the biggest proponent of the imaging, I would rather like to go a step back, and I would rather like to say that I should just stop at the risk factors and start treating the people so that the disease could be eliminated completely. And I think the best way of going that would be with the risk factors, and I think I certainly believe that this new hypercholesterolemia guidelines have delivered a lot, and more guidelines coming with the non-statin addition onto top of the statins now, which we should see soon from the American College of Cardiology, or with the PCSK9 and all coming. We are just going to present the data from Chimane jungles of Bolivia, and then data coming from my spiritual guru's place. We are postponing the coronary artery disease by a decade in one group and by 3 decades in the other group, just because their cholesterol levels are 40 or even less than 40. So if we have got that in our hands, I don't need imaging. And specifically what has been told, and I tell you that it raises the curtain, what the PESA study has demonstrated to us, that we believed that people only start developing the disease at 60 years of age and all. I think you have done it, you have demonstrated it. I don't see any reason why we should have any more algorithms.
Sahith Fayar will give us the answer. This is a reason why we move into behavior. I started with the vulnerable plaque. I think we defined the topic. And I'm now in behavior, and the reason is because now you face a situation which you say is no problem because we don't need imaging. Our studies now is to pick up these 10,000 people and see if we can change their behavior. And I will tell you, it's extremely difficult. So what I'm really saying is we start with a vulnerable plaque, but we are really going to a behavioral problem. And that is, now what we are doing is showing the arteries to people. There is a lot of calcification in the iliofemoral region or ultrasound. Are you going to change behavior? And then we have different ways to change it. So what I'm saying is, and this is how I wanted to finish today, is that we started with a vulnerable plaque, but we have a huge issue here. And that is, we don't change. Sahih.
Yeah, I mean, to think a little bit more even to the future, in a sense, that empowering the patient in terms of getting their data, to document what's going on. I mean, we've seen it happening already in people who are taking exercise regimens or getting into this, and they're measuring them with these wearable devices. And if we can maybe bring that even closer in terms of documenting the disease in a very easy way, to encourage them to undergo these behavior changes, which, as you know, are very difficult to do. So you need that motivation. The other aspect, which we didn't touch a lot on here, why would you need imaging in a way? A lot of these new drugs are going to become more and more expensive and more targeted. And that's why you may need some way to fine-tune beyond what you can do with risk factors. So that's touch on that also a little bit.
Well, I'd like to finish before discussion by reading 2 statements. One comes from Crystal. And she says, accurately predicting when and which coronary plaque is destined to rupture and cause a catastrophic event remains an impossibility. And she says, traditional risk factor models continue to be very good tools to identify the susceptible patient. In addition of non-invasive imaging techniques such as ultrasound and coronary artery calcification allow us to risk stratify them even further in a cost-effective way. Focusing on identifying a single lesion may currently be a short-sighted and limited approach to tackling such a complex disease process. I think it's a great statement. And now comes the statement, which is perhaps more apocalyptic, which is the statement made by Erling Falk, who has been a pioneer in the field. I mean, it's just, and what he says is, let me see. Let me read it, it's here. It's a very good statement that I think puts the whole thing in context. And he says, clinical benefit of searching for vulnerable plaques remains to be documented. Considering the multifocal nature of atherosclerosis and the complex interaction between plaque size, plaque composition, local flow disturbances, and the actual susceptibility to thrombosis, trying to predict the fate and the clinical impact of a particular plaque may be futile. Atherosclerosis is a systemic disease calling for a systemic approach, focusing on cardiovascular risk factors and the overall burden of disease to ensure appropriate identification and treatment. Those who are at highest risk, these are the vulnerable patients. That has nothing to do with the vulnerable plaque. That's basically the statement that he makes. I think the subject is quite fascinating historically, but I think it tells us how humble we should be, because we start with a focal plaque, which we have learned a lot, and we are ending up what we do with our brain to behave. And the reality is the reality. I don't know if you have any further comments. If not,
It has taught us a lot. There is no doubt about it, Dr. Fuster. I mean, like we have learned the disease only because of getting into vulnerability.
Yeah.
We wouldn't have reached here if we had not gone into vulnerability.
No, I agree. I think has not been a waste of time. That's for sure.
I think we know how the beautiful Chinese vase breaks. They figure out how to keep it from falling down and breaking. That's the magic, and I think that the behavioral change is the only way, but it's a very tough one.
Yeah, thank you. Any question, comments? Yes.
About zero. It's just unusual. So it seems to me the burden of finding a use for the newer technologies is very high, because as it is, the success is spectacular. In terms of the gray zone, the data is helpful. The primitive data that we use on the street is helpful because it tells you how crazy you have to be about a patient. If the patient is low to moderate risk and has trouble tolerating a medicine, you know, you can back off a little bit without thinking you're killing the patient. You know, so as it is, the information is extremely useful and extremely effective.
Thank you. Other comments or questions?
Yes. This way.
My comment relates to the risk stratification tools. We talk about starting statin or aspirin, as you were referring to, based on some of the risks and some of the characteristics we see on imaging. But I just haven't seen a caution in the literature in this regards in terms of we look at the history or 10 years follow-up as if we are watching a natural history of a patient, but most of these patients are on statin already based on what was seen in the imaging. We follow them for 10 years, we give them a medication, say the medication was perfect. We will not see any event. And then we end up saying that there are no events, so they should not be getting statin. I feel we have to have some caution in terms of accounting for that treatment effect and not making a conclusion at the end saying that it is not beneficial because the event rate is low. We don't know event rate is low because the treatment worked, or event rate is low because it is a natural history.
Well, first of all, I think I understand what you say, but first of all, these patients that many have angiograms and you don't see anything are not on statins. The people on the statins, you know, the studies that we are presenting in our classification, I can assure you they were not on statins. They are in statins when they reach group 3, group 4, or 5, and there's an angiogram that shows significant disease. But I think we have to be very careful and start giving drugs to everybody, just with very subclinical minor disease. And this is the point I'm trying to make, that now we are entering a stage of who should be treated subclinically. And that, to me, is a new phase. And I think we are beginning to think in this way, but I don't think we have an answer. But in the classification I gave, the literature that I presented is really literature. They were not taking medications, those in class 1 or class 2. Other comments or questions?
Thank you for a fascinating discussion. The issues to who to treat in subclinical disease is an astronomical daily clinical challenge. And in view of the polypill concept, I share comments with Sandy that we don't see heart attacks. The groups in our patients that are being treated, and again, it's not a study, but doing this thing for a long time and identifying clinical disease, I cannot recall the last patient that had an acute MI that's under treatment. I find that to be very powerful. We've seen patients with disease that have a calcium score of 27 that require to be stented in a proximal LAD. So it's complex and clearly taking it all into account. Some of the guidelines also we see with SPRINT, we know that we have to treat to be more aggressive. Do you think then that we're just not there yet in terms of recommending more aggressive treatment? And how does that affect your idea of the polypill?
Well, 2 comments in that context. The first is the polypill is only justified for secondary prevention because the data on what you must take comes from secondary prevention. In primary prevention, each of us is different. So I don't think we'll be ever a polypill. Actually, there is no polypill approved other than ours, and the reason is because we went directly to secondary prevention. All those use of polypills of primary prevention never made it because the industry were not interested on. So I think we go into secondary prevention. But there's a second issue. The patients that we see in our practice is not the world. That's I want to make this comment. I know many times Dr. Friedman and others says, well, my patient and so forth. Well, I can also talk about my patient, but I will tell you the patients in the street, the sense of vulnerability doesn't exist. And when you go into a whole world and you begin to look at who is doing what to prevent cardiovascular disease, you realize that your clientele is quite different to what is out there. So I think we have to really be sure that we are in the context of these people. So it's just 2 comments. Any other comment, question?
Those people you're describing don't have docs.
The what?
The people you're describing don't have docs.
They don't have dogs. No, come on, Sandy, that's not the, excuse me, my friend. I have been president of the World Heart Federation. I have traveled all over the world. And I tell you what I thought is what I present to you today, that something has to be done, that we cannot continue to do the usual with the clientele that we have. This is not the world. It's absolutely not. Let me tell you, in countries with low economy, do you know how many people are taking statins that they should? This is in the just recent study from Yusuf, 3%. The other 97% are not taking statins. The same happened with ACE inhibitors. So I think we have to really, in the polypill, one of the advantages is much cheaper, the distribution of these pills together than you go individually. So no, people don't have dogs. That's the reality. And I think we should be very aware of that. Any other comments? Okay, well, thank you very much to all. Thank you. And thank you, Murad.